Hello, dear colleagues. I'm Emek Kocatürk Göncü from Koç University School of Medicine, Istanbul, Turkey. Today, we are shooting the first video of the UCARE LevelUp program. The UCARE LevelUp program is a physician information and education platform which aims to update physicians on recent developments in urticaria and establish a platform for interaction among physicians who treat patients with chronic urticaria. So today we are going to speak on how to confirm chronic urticaria and exclude differential diagnosis with my colleague, Associate Professor Dr. Andaç Salman from Marmara University School of Medicine. We are from Departments of Dermatology, Istanbul, Turkey. So Andaç, welcome.
Hi everyone.
So I'm going to ask you some questions.
Okay.
And my first question is, what do you do for examination, laboratory workup, and diagnostic workup in a patient with chronic urticaria?
Thank you. And I'd like to welcome everybody to our first video on UCARE LevelUp. And the first question is, I think the history and the physical examination are essential in the diagnosis of urticaria, as in all medical conditions. And if you think the transient nature of the lesions, the patients are usually free of the lesions at the time of the examination. I usually experience this. They are free of lesions and they cannot show anything. And I think in those cases, photographs taken by the patients might be of great benefit for us. And if we see a lesion, or if you see a picture photograph of the lesion, I think we should define first what a typical wheal looks like. I think a typical wheal has three features that we should look for in history and physical examination. It is typically a well-demarcated swelling, and it can size from millimeters to centimeters. And we usually see a surrounding reflex erythema around the lesion. And also the lesions are usually, most of the time, associated with itching, sensation, and sometimes, although rarely, with burning. And one of the most important hallmarks of typical wheals is the resolution the time to resolution of the lesions. And the individual lesions should resolve within 24 hours. On the other hand, we are going to talk about later, but angioedema lesions are more deeply swollen, and sometimes they are skin-colored rather than erythematous, and it may also affect the mucous membranes. And also, in addition to burning, tingling, in angioedema lesions, pain is very important, and it is usually the main complaint of the patients. And also, a slower resolution of the lesions in angioedema may be expected. So the individual angioedema lesions may resolve within 72 hours, up to 72 hours. And other than the history and the physical examination, the recommended diagnostic workup, the laboratory workup, is actually quite limited for a typical chronic urticaria patient. And in the international urticaria guidelines, intensive and costly general screening tests are advised against in those guidelines, and the basic laboratory workup only includes a differential blood count, a CRP and ESR levels, total IgE levels, and anti-TPO antibody levels. And the physical examination and those basic tests are usually adequate for the assessment of patients for differential diagnosis that might mimic urticaria, and we'll talk about later. And further testing is only indicated if only the history, the examination, or the basic workup indicates that further testing in those patients.
Yes, thank you. This was really helpful, Andaç.
You're welcome.
So do you want to ask me any questions?
Of course. If I have you, and when I get you in, and we can ask about urticaria. I have many questions, but we have a limited time. And my question is, what differential diagnosis do you have to consider in a patient with recurrent wheals? What are the clues for each of these conditions?
Yes, Andaç, you already mentioned the nature of urticarial lesions, and I want to just put some remarks on the transient nature, the migratory nature of the lesions. They are erythematous, and each is a really important feature of the urticarial lesions, and we find them usually edematous lesions. So these are the characteristics, and they disappear in 24 hours without leaving a stain. Any marks are seen. But sometimes, as you mentioned, patients sometimes refer to us without any lesions, and this is like a routine in our clinics. They usually show us photos of their lesions, and we can make the diagnosis of urticaria with even photos. But sometimes urticaria diagnosis may be tricky, like the lesions may last longer than 24 hours, or the lesions may leave some marks after disappearing. So these are some clues for making differential diagnosis. And the first important differential diagnosis is urticarial vasculitis. And we also need to exclude autoinflammatory syndromes. Sometimes bullous pemphigoid can appear with urticarial lesions. We had a patient like this. The patient had urticarial lesions for 2 years, and after 2 years, she came with the blisters, and when we make the direct immunofluorescence study, we saw that the patient had bullous pemphigoid. And there can be eosinophilic cellulitis. Sometimes insect bites might mimic urticaria, and we can have mastocytosis, especially in children. So the guideline suggests to follow this diagnostic algorithm in patients with WHEALS and angioedema. So the first question is, do you have fever, fatigue, bone pain, arthralgia? We know that usually urticaria patients, chronic urticaria patients, are not sick. They are feeling well other than urticaria lesions or angioedema. They are bothered by the symptoms, but they are doing well in their routine life. So if they say that they have fever with the lesions, or they have fatigue, bone pain, arthralgia, then we have to keep in mind the possibility of autoinflammatory disease. And if the lesions are lasting longer than 24 hours, we need to keep in mind the possibility of urticarial vasculitis. Then we may make a punch biopsy and see the leukocytoclasia and fibrinoid necrosis and the biopsy. Then we make the urticarial vasculitis diagnosis. And if the lesions are induced by some triggering factors, then we can make the diagnosis of chronic inducible urticaria. And here you see an urticarial vasculitis lesion. The urticarial vasculitis is characterized by lesions lasting longer than 24 hours. They are usually dark red, and they leave purpura or hyperpigmentation after resolving. And the patients usually mention about a tenderness or burning sensation along with the itching sensation. So, and the autoinflammatory syndromes are characterized by WHEALS lasting for usually 24 hours, but these lesions do not have itch, and the patients have accompanying features like fever, fatigue, arthralgia, myalgia, and bone pain. Yes, you see here we have many differential diagnoses of urticaria, but the lesions last longer than 24 hours in many of these lesions. And we have to also keep in mind that the patient may have inducible urticaria accompanying spontaneous urticaria, or they may have only inducible urticaria, but inducible urticarias are characterized by lesions that last shorter than the usual spontaneous WHEAL. They usually say that the lesions disappear within 1 hour, except delayed pressure urticaria. So the question to ask to inducible urticaria patients is, can you make your wheals come? Then the patient may put an ice cube on their arm and can show you that they have cold urticaria, for example. So Andaç, do we need to do allergy tests in patients with recurrent wheals? The patients are always asking us this question.
Yes.
And on which subjects shall we do allergy testing?
Yeah, this is the most common question I think I receive from my patients in the outpatient clinics, and I think this is a very common problem also in my practice. And the first of all, that we all know that urticaria is not an allergic disease in most of the cases, and actually an IgE mediated food allergy, a real allergy, is rarely the underlying cause of chronic spontaneous urticaria. And so allergy testing, I mean the prick testing, is seldom indicated in chronic urticaria patients. But the patients are usually looking for some centers to do some allergy testing and to see the underlying causes. And this causes loss of time for the patients and loss of money for the patients. And I see this as a common problem. So we should do an allergy testing only in patients that we see a clear relation with the onset of the lesions and with some ingestion of some foods or other possible allergens. But on the other hand, in a different condition, a different entity in immunological contact, urticaria syndrome, okay, we should do an open test, an allergy test or prick test to confirm the diagnosis and the culprit allergen in those cases. But in case of chronic urticaria, it's most of the time it's not needed. Also, during the active phase of urticaria or in the presence of symptomatic dermographism, and prick testing may yield false positive results, then this leads to unnecessary and cumbersome diets in patients with chronic spontaneous urticaria. Some patients are coming to us and they have a huge list of diet and they are not allowed to eat anything. So it's not very practical and it's not very feasible for the patients. And also the treatments that are used for chronic urticaria, including the antihistamines, usually suppresses the prick test reactivity, and this causes, on the other hand, false negative results. So in case of suspect for Ig-mediated allergy in a patient with WHEALS, the relevant medications should be stopped before testing, and we should choose the patients very carefully, not to cause unnecessary diets or unnecessary testing in those patients.
Yes, thank you. It was a clear answer. So no need for a routine in a patient who has routine WHEALS every day. So it's very clear.
And,
okay.
And the other question is that, okay, we don't need allergy testing, but do we need any diagnostic tests to look for CINDU, or how do you exclude CINDU?
Yes, we already mentioned we may have inducible urticarias accompanying with chronic spontaneous urticaria, or the patient may have only isolated inducible urticarias. So these inducible urticarias are different from chronic spontaneous urticaria because they need a triggering factor for the WHEALS to come out, like stroking the skin in symptomatic dermographism, or cold air or cold objects in cold urticaria, delayed pressure urticaria, solar urticaria, heat urticaria, vibratory angioedema. We have many types of physical inducible urticarias and also cholinergic, aquagenic, and contact urticaria. These are the non-physical inducible urticarias. So these differ because the patients are usually younger than the spontaneous urticaria patients, and the lesions tend to stay for a maximum of 30 minutes. They disappear within 1 hour, except for the delayed pressure urticaria, in which the lesions came out after 6 hours of vertical pressure, and they may disappear in 72 hours. And then the inducible urticarias tend to last longer than chronic spontaneous urticaria for a duration of the disease, if we take it like this. And so these are the differentiating features between spontaneous urticaria and inducible urticaria. But for making the diagnosis of inducible urticarias, we need to do some provocation testing. And these details of these provocation testings are really very well covered in consensus recommendations for inducible urticarias. It was the 2016 publication, but it still is very updated. So we need to do some provocation testing. For example, for symptomatic dermographism, we can use a wooden spatula, or we can use a dermographometer, but it's not very easy to find. We can use a freak testing device, which is a very practical device that can also give us scoring and activity of the disease. For cold urticaria, we can use ice cube testing, or if we are lucky, we may have a temp testing device which shows the temperature the patient reacts to. So you can give a definite temperature that the patient reacts. And we have many types of testings, details of these testings for inducible urticaria patients. So I invite my colleagues to read these papers and see the details of inducible provocation testings for inducible urticarias. So, Andaç, I already mentioned that there can be some types of autoinflammatory syndromes which can manifest with recurrent WHEALS. So how can we make the diagnosis, or how can we exclude these systemic autoinflammatory syndromes in a patient with recurrent WHEALS?
Yeah, thank you. And as you already mentioned, in a patient with presenting with WHEALS, and before confirming the diagnosis, we should first exclude urticarial vasculitis and autoinflammatory disorders. But to confirm or to exclude these diagnoses, first we have to suspect of those conditions. And in patients with recurrent or persistent fever and associated with a variety of inflammatory symptoms, including arthralgias and organomegalies, lymphadenopathy, and increased inflammatory markers, then we should think of some additional differential diagnosis other than urticaria. And those include mainly the autoinflammatory syndromes, and some of them are exclusively present with urticarial rash, in addition to those symptoms that are mentioned just before. And those syndromes are the first one is the cryopyrin-associated periodic syndromes, the Schnitzler syndrome, and the familial cold autoinflammatory syndrome too. And in general, as I said, an unexplained recurrent fever and some bone complaints, some bone pain, joint pain, organomegalies, and lymphadenopathy, and increased levels of CRP or ESR should be suggestive of these conditions. And in addition to those, for example, in Schnitzler syndrome, and we can expect to see a monoclonal gammopathy, mostly with an IgM spike. And for example, in CAPS syndrome, the urticarial lesions are usually exacerbated by exposure to cold. And also we can expect some sensorineural hearing loss, aseptic meningitis, and amyloidosis can also be seen in CAPS syndromes. And also sometimes histopathology may be suggestive of these conditions. And in those patients, we see a more neutrophilic infiltrate in the lesions of those patients. Of course, we also can see them in chronic urticaria lesions, but in addition to those symptoms and findings, I think a neutrophilic infiltrate is also helpful in confirming the diagnosis. And in addition to patients with presenting WHEALS, we also see sometimes patients present with only angioedema, with isolated angioedema. So other than urticaria, what conditions can we think of in such patients?
Yes, Andaç, yes, you are right. Angioedema usually accompanies chronic urticaria patients. We see angioedema in half of our chronic urticaria patients, but sometimes the chronic urticaria can manifest only with angioedema. It's the 10% of the patients. So, then this causes some doubts in our routine practice, because maybe this patient doesn't have urticaria, but may have other angioedema-related syndromes, such as the hereditary angioedema or acquired angioedema. These are the bradykinin-related angioedema. So the first question in a patient with if it's an adult patient, then we need to ask if the patient has only angioedema, isolated angioedema without WHEALS. Then the first question is, are you using ACE inhibitor treatment? Because it's the most common cause of angioedema in the adult population. So first, ruling out ACE inhibitor induced angioedema, then we can also consider other types of angioedema. First, angioedema can be mast cell mediated, and it can be originated from type 1 allergic reactions, but it's usually in the emergency room. So we as clinicians making routine polyclinics, then we consider them as having chronic urticaria or acute urticaria, but sometimes, as I mentioned, it can be bradykinin mediated. And if this is the case, then the patient may have hereditary angioedema, acquired angioedema, or drug-induced angioedema. And these patients usually tend to have some features that warn us about the possibility of bradykinin-mediated angioedema. For example, they are recalcitrant to antihistamine or corticosteroid treatment, and also omalizumab treatment. And these patients tend to have some prodromal symptoms like headache or nausea, some kind of bad feeling. They usually say that they feel that the angioedema attack will come, and they may have family history, and the angioedema starts usually on the first or second decade. And the patient may have triggering factors such as dental procedures, menstruation, viral infections, and they may have unexplained abdominal pain attacks, and of course no urticaria. Then we must suspect in these patients the possibility of bradykinin-related angioedema, and so we need to order C1 esterase inhibitor function and also levels, or if we can't find these, we have to order C4 for excluding bradykinin mediated angioedema. So I hope it was clear.
Yeah, thank you so much. I think we covered all the subjects we plan to talk about. And thank you for your clear explanation. And it's always a pleasure.
Yes, I also thank you for your very good answers, covering all the aspects of differential diagnosis, making a differential diagnosis, also making workup in a chronic urticaria patient. I hope we could help some of our colleagues, and I hope they find it useful, this video, and if they like, they can share it. And so it is an activity of UCARE LevelUp program. This program is made for increasing knowledge on urticaria. Okay, hope to see you in further videos, and thank you so much, Andaç. Bye-bye.
Bye-bye.